loud enough for reasons unknown to anybody.
Good evening. I'm Dr. Mark Trannon. I'm a member of the board of the Princeton Adult School. It's my privilege as the token physician on our board to be the introducer tonight for Professor Reinhardt. Professor Uwe Reinhardt is the sixth of our 8 lecturers in this course, and it's a great pleasure to have him here tonight. Professor Reinhardt is a native of Germany and has taught at Princeton since 1968 after getting his PhD at Yale. In 1978, he was elected to the Institute of Medicine of the National Academy of Sciences, and for about 15 years, from 78 to 93, he served on the board of trustees of TIAA. He's currently a trustee at Duke University, I believe, and Duke University Health System. He has a huge CV, and I won't honestly try to do anything other than just highlight 1 or 2 other things. He's the author of a book, Physician Productivity and the Demand for Health Manpower and Economic Analysis. He's an authority on the nation's healthcare system, and he is Princeton's James Madison's Professor of Political Economy. He has been served on many editorial boards, and I note that you were on the board of the New England Journal of Medicine as well. So there's a lot of experience in the healthcare area. So that brings us to the topic of tonight's lecture, and that is in particular sailing into a perfect storm: economic trends in American healthcare. Please welcome Professor Uwe Reinhardt.
For this kind introduction. I changed the title a little bit because, frankly, I forgot the other one. It's very much the same idea, as you will see. I want to start by describing health spending in the United States. And what I did here is take the total health spending data. They're usually assembled by the U.S. government Centers for Medicare and Medicaid Services, which is what used to be called the Healthcare Financing Administration. And the Bush administration, every administration changes the name to leave a stamp on health policy. And that was initially in the first 2 years. Health policies changed that name. They had a contest of that, by the way, and I submitted the name Senior Health Insurance Trust, which I thought would be a very nice I never figure out why. They came up with CMS, but it's Centers for Medicare and Medicaid Services. So I actually, in writing, it's in the published journal, asked the head of that, where did one of the M's go, and which M don't you give a damn about? I think it's Medicaid. Well, if you take their data and then divide through by population to get it per capita, and then adjust it for general price inflation, and you could use the consumer price index. I use the GDP index, which means these are dollars that always buy the same amount of GDP, roughly. You get the red line, dots. And of course, if you are sober enough to hit that button trend line, anyone can now, even without a PhD, get this black line. And the best fitting one had this particular shape and that equation. In this area here, you see that until about '89, the health system literally marched right on the trend line. And then it veered off a little bit in the later Reagan-Bush years, and no one really knows why that happened. I think my interpretation is the Reagan administration deregulated the supply side. Certificate of need and all these things were abolished, but there was nothing on the demand side to give countervailing power. And so the system went sugar for a little bit. And you know how that is. God got mad, and when God gets mad, he sends locusts. And the locust sent was called managed care. Felt like the Egyptians a little bit, and, which wasn't really managed care at all. It was managed cost. Basically, it was scaring doctors in the hospitals enough to give huge discounts till the doctors in hospitals figured there was nothing there on the other side. Those insurance companies had very little power and just told them to take a walk, which, as you remember, wasn't it Robert Wood Johnson Hospital told Oxford Health Plan to take a walk, and they came back like Henry II in Canossa and begged forgiveness and paid higher rates. That's how that goes. And so we're back on the old path. Now this little coefficient up there means that every year the American health system wants to have 4.5% more purchasing power per man, woman, and child alive than the year before. And if you understand that, you're on the way to become an actuary. Now, if I do the same for gross domestic product, GDP per capita, I get this little line. There's some wiggles around it. We call them recessions or downturns, but they're never very lasting. Since World War II, we've had a very smooth economy, actually, and that you have to credit economic research and people like Ben Bernanke now and others who managed to beat tendencies for recessions with stimulants. What you got here is a pretty smooth line, and this coefficient here says GDP per capita in the last 35 years, or 40 years almost, has grown by about 2% per year. Not every year, not even every half decade, but in the long haul. And you can pretty much expect that to go on for the next 50 years. Although Social Security uses 1.5% in making its forecast, which gives you some of these dire forecasts. If you assume 2%, things are not nearly as bad as what they say it is. I think 2% is not unrealistic because we haven't even begun to exploit the information technology and nanotechnology and all those things just on the horizon. So if you now subtract one from the other, you are a full actuary, and I will certify you thus. Over the long haul, the American system wants to grow about 2.5 percentage points faster than the GDP as a whole. And so far, the health system has gotten that for 40 years, and the actuaries of CMS, certainly for the next decade, have used exactly that growth differential to make their projection. Because no one really knows what will happen. But if you use it, you usually come pretty close to what it'll be. So this is the actuaries. The green is the projection. Look how smooth that is. And you see that little managed care wrinkle here in the 90s. And look at how smooth. That is that 2.5% rule. We're now spending about 1.8 trillion, or 15.4% of GDP on healthcare. And that's supposed to go to 18.7 or 3.6 trillion. So health spending will double, but of course GDP grows as well, and therefore it's only 18.7. Still, that is a lot of money. As a percent of GDP, it's, as I said, 18.7%, and you can really see the effect of two things in the 90s. One, health spending was controlled by managed care, and secondly, GDP grew very rapidly. So the numerator was growing less slowly, the denominator was growing rapidly, and you had it flat for it's unique in history that it was flat for almost a decade. Now, when you expand this, I did this here to 2013, the 18.7 is 2014. 2013, using the 2.5% rule, I get 18.5% and 40% by the year 2050. So if we stay on this trajectory, 40% of GDP will go to health. Mind you though, GDP will be huge because it grows at 2% compound. So it'll be a big, big slice out of a much, much bigger GDP. But by that time, we will literally have to give up some non-health GDP. That starts at around 2030, where at this growth path, eventually we will have actually fewer cars, fewer houses, and it'll go into healthcare if we stay on this trajectory, which we might not. You know Herb Stein's famous theorem, if a trend cannot possibly persist, it probably won't. If you compare this to other nations, we are a big spender. 15.2% in 2003. Those are the last numbers. They're put together in Paris by the OECD as comparable as they can make them in international dollars. That is, these are dollars that buy the same amount of stuff in every country. Switzerland, the next highest spender, 11.5. They have a very fine health system. A lot of people think in terms of health status, quality of care better than ours. Ours can be exquisite or terrible. It depends where you look. Theirs is more uniform. Germany, 11.1. That, of course, because they have East Germany, it's a sort of like adding Mexico to us, adding their GDP, but give them our health spending. That's what happened when East Germany became part of Germany, and France, and so on. So these countries, on a per capita basis, in 2003, Switzerland spent 67%, only 2/3 as much as we did, and neighboring Canada, 53, about half as much as we spent. Part of that, of course, is because we are a richer country. There is a very tight correlation between GDP per capita and health spending per capita. Richer nations spend more on health care. And as a general rule of thumb, again as an actuary, it has been true for us for the last 40 years, and it is true across the OECD, that generally about a 10% increase in GDP per capita raises health spending per capita by about 13 to 14%. That's a natural thing. Why? Because healthcare is a luxury good. That is, as you get richer, you want disproportionately more of it and fewer potatoes and fewer food in general. There's a limit to how much you'll eat, but there's very little limit, or there are limits, but less so for health and education, where we will, education is just like this, by the way. So there you go. Now, one, you often hear that people will say, well, these spending trends, they're driven by the aging of the population. And there is a sort of an anti-aging thing in the debate of health policy, the greedy geezers eating us poor and stuff like that. I think, personally, this is total nonsense, but it has some currency out there. As you know, there were two major discoveries in World War II. One was penicillin, I think it came out of England, penicillin, and the other one was that libido could be inventoried. That had not been known before. But it was true. The GIs proved it. They came back after 5 years in the trenches, or 4, and amortized a huge inventory. Which then we got the baby boom that you see here. And these are these horrible people who wrecked the nurseries, remember? They did that. Then they wrecked the high schools. Then they wrecked the colleges. Those are the ones storming up and down, students for democratic society. And it's but democratic. And then they will, of course, wreck the nursing homes. Once they're sort of like a rat through the body of a python. Someday they'll be gone. And the question is, what will they do to us? You know, everyone says they're going to ruin the country. And of course, depending on how you do this is a wonderful slide. It's enough to scare the heck out of you. This shows the percent of the American population growing over age 65, sort of think of just millions of Bill Clintons. Some idea what I'm talking about. Viagra Plus will be an entitlement. There they'll make it. You know what that is. They use the old Viagra and put it in a tranquilizer. Yes, and then makes you go out and look for a lover, but if you don't find one, you don't give a damn. Bill Clinton really needs that help. We have millions of these characters. So you have that firmly in your mind, this tsunami coming, ancient tsunami, overpowering the rest of America. And then I'll show you health spending per capita, and any physician will know that. This shows, if I take this is 1999 data, it's the last I could find. This was done by Mayara White and David Cutler up at Harvard. And you need a fair amount of research to adjust for everything here. But if you say, let us call the health spending of a 34 to 44-year-old, the per capita spending, call that 1 as a benchmark. Then relative to that, somebody 65 and 74, on average, has health spending 3 times as high, and 75 plus, 5.6 times as high. If you go very high, 80 and more, it's actually cheaper again. They are less expensive. And then women are more expensive at the younger ages, when in the childbearing ages, but they're cheaper in old age. Men cost a lot more. My wife has an expert. I tell her it has to do with the fact that men treat women much more nicely than the opposite. We just crumble from the assault. She says they're just biologically superior, which I think any physician will tell you is really. They live also 7 years longer. I call it the male health crisis. We die 5 to 7 years earlier now because we're very fragile. But it's also even true at babies. More male babies die than women babies, so there's something wrong with that. Now, we're bouncing into that expensive part of the graph. So I have that first graph to really scare you, and then I show you this to really scare you. I say, put these two together, and it's enough to make you want to jump off a bridge. But before you do that, let me walk you through some numbers. The way you actually explore the effect of aging per se by itself on health spending, this is something that I asked Julie Hudson of the Agency for Healthcare Quality Research, a government agency. They have a huge database, and if you give them the specs, they can run a simulation through for you. And I say, here's the simulation I'm asking you to run. The population doesn't change in size. The age-specific health spending per capita, the graph I just showed you, doesn't change. Every 75-year-old male will, on average, get the same 20 years from now as they do now. Nothing changes except that fixed population gets older. There's a higher percentage of elderly. Simulate to me what will happen to health spending. And what she simulated, for men, on average, if that's all that happened, health spending would rise by 0.5 percentage point per year. For women, it's only 2.6, because somehow they're cheaper. And if you combine the two, it's 0.4. So less than 0.5 percentage point of the annual increase in health spending, which is 4.5, can be explained by aging per se. And you can say, how could this be, given the graph you showed us? Well, there's a trick to this that I'll show you in a minute. So aging per se is not the problem. What really is the problem, that for every age group, young and old, health spending per capita rises at a very high 6 to 7% per year, in part, and in large part, because the health system can do ever more spectacular things. I mean, just think, if people sort of complaining this inflation is also expensive, and we health economists always say, yeah, maybe what we should do is, I give you a choice. You can have today's healthcare, today's cost, or 1980 healthcare, 1980 cost. What would you pick? And everyone goes for today, because you will survive things you wouldn't. You'll have stents that weren't even talked about. We are now talking about implantable devices like stents that can be implanted through a tube that'll control incontinence, that'll control migraine. That's about 5, 10 years ahead, not even 10 years from now. You will routinely have these things. You have defibrillators that are so small they fit can be implanted. It was just wonderful stuff. And it's expensive. We should not expect this to be cheap. So the projected health spending, this was another study, not mine, Bruner, Waldo, and Cusick, 1992. They did the same exercise. They looked from 1990 to 2030, and then they simulated what would happen to total national health spending if the population stayed the same, everything stayed the same, except the fraction of population elderly would rise, as predicted by the actuaries now. That includes the retiring of the baby boom. And it would, in 1990, health spending was $585 billion, and in 2030, it would then be $728 billion. Not a big deal. But the actual forecast they had, it'll actually be 14 trillion health spending. So this red can be explained by aging, and the rest, the rise in health spending per capita for every age group, is the blue. Even kids, 20 years ago, kids weren't on Ritalin, kids were not on drugs. Now kids are pumped full of drugs, all kinds of drugs. To make them taller, to make them more attentive, to make them more obedient. 20 drugs, you can make a teenager livable. So, all of this is for just about every age group. This is the answer here. You see, at Princeton, I insist that when you plot percentages, you have on the axis 0 to 100%. Because only then will you really know what goes on. The trick of fooling people is to have that only go from 0 to 20. I can make anything look scary, absolutely anything, just by scaling the axis. I teach students how to do that. I call it SIFFing, structuring information felicitously, which is lying without really doing it. You're not really lying, you're just creating an image that makes the recipient of that information lie to themselves. And that's what I did. This is not a tsunami. You couldn't even surf on this. It's very gradual, and it'll never be more than 20%. So, and in addition, America, Canada, Australia, and New Zealand will always be the youngest in the OECD. Our national anthem should be forever young. Germany, Sweden today is already as old as we will be in 2040. Germany today is as old as we'll be in 2025. Japan today is like Sweden. I always think the Swedes, these vigorous blondes, they make Volvos and sex. This is the Swedes, they just make Volvos. So we are the young, vigorous nation and always will. See, that's the trick here. Look at this. And this, of course, is so many what I call charlatans on the speaking circuit. They draw graphs just to scare you and say we need to totally dismantle Medicare because look at what's happening. And it's not so fast. This is the least of our problems, is the aging of the population. I have a paper on this, which in Health Affairs, you can see where I actually worked this out, and it's generally accepted. I've seen papers in Canada, Australia, France, making the same point on the aging. So that's really not the issue. Now let me look at the Medicare program and projected spending here as a percent of GDP. I downloaded that. You can get it on the internet. Trustees report. Just Google the Social Security Trustees report. You get these beautiful reports, and you can steal their graphs. Right-click, copy, and you got it. So here is Part D as a percent of GDP. This Part D that was passed by President Bush and the Republicans is an extremely liberal program. It is an astounding thing to come from the pen of Republicans. Also, in a way, it was weighted towards the poor. It should be a liberal stream. I don't know whether they were upset about it, but it's a huge amount of money that's being budgeted here. Then the green is Part B, which is physician services, lab services, which you pay with your Part B premium, which, however, pay only 25% of the total cost of Part B, the physician and lab stuff. Now these you take from the bottom up each. I mean, they're not stacked, these, always from the bottom. And then hospital, I don't know what else is hospital, some nursing, I forget where they put home care. They shifted between these parts, is the blue. Now if you stack them and add them on top of each other, you get this, whatever that is, crimson line. So at the moment, it's about total health spending on Medicare is about 2–3% of GDP. And they predict that it'll be closer to 14% by 2070, close to 2080. Of course, you would have to be really drunk to believe any forecast to the year 2080. Who knows if we still speak English? Maybe we'll speak Chinese. I mean, who knows what'll happen till there. And then they assume only 1.5% GDP growth. You can make these graphs look any way you want to by assumption. I personally think this is a little alarmist right there. But they go on, this is another graph here. So they say as a percent of the total expenditure from 2000, where that line is where we are now. The red is total Medicare expenditure. And then payroll taxes is this little thing down there. Then you have premiums. These are the premiums you pay, and that had risen quite rapidly of recent. Then you have state transfers, that little yellow sliver. What that is actually the states now have to write checks to the federal government because the states no longer pay for the drugs of poor Medicare, the dual eligibles. The Medicare now pays for that, and the Medicare recovers that from the states through a thing called a clawback. So it's a little check writing there. Then you have general revenue transfers. That is basically the piece of the Part D, the drug program, and the Part B for physician and lab services that is not paid through your premiums, but paid from general taxation. And this is the so-called, so that always covers, by definition, there's never a deficit, because whatever is spent for drugs and physicians and labs will be covered from general revenues or your premiums. So that's never in deficit. The only thing that can be in deficit is hospital care. And what you're looking at is this difference between this line and the total is the hospital trust fund deficit. And we'll probably borrow that from China. I mean, we now do it. How long the Chinese will be willing to do that, I don't know. But so far, the Chinese have been willing to. They're buying, Chinese and Japan, buying 80% of all the new government bonds sold. Somebody probably told you that. And so it's very nice of the descendants of Mao Zedong to bail out the essentially a Republican government. I think it's Now, the proposal is sometimes made, we'll privatizing Medicare, that'll bail us out. We have to privatize this to make the program sustainable. And if you live in New Jersey, you will not understand it. To understand why that works, you have to live in Washington, D.C., where our whole cerebrum is wired differently. An increase in spending is called a cut there. It's not even English. I kid you not. Budget, real increases in the federal budget are called cuts. It's the strangest town if you're ever there. Usually when I come home and take a bath, get drunk to cleanse my brain so that I can function again. So let me show this privatizing. The fact is that you have a choice now as a Medicare recipient to go and join an HMO. It could be Aetna, it could be any one of these. And then the government will pay them, write them a check for you, and you may have to pay a premium. Usually you do some premium. And for that you get pretty good coverage from the HMO. Although limited choice of doctors, you get pushed around. It's managed care. Now, you may recall when the drug bill was passed, a month after it was passed, the White House says, you know, it's not going to be 400 billion, it's going to be 536 billion. Remember that? There was a little estimation error there. And some Republicans, among them Jim Nussle, got mad and wrote to the Congressional Budget Office, where is the difference? And there are all kinds of differences, but one that struck my eye was the administration's estimate is 32 billion higher of that. There were many other estimation errors or differences, but they say the administration assumes more elderly, 32% join Medicare Advantage, than the 9% the Congressional Budget Office assumes. Both estimates assume that many of the participants are in areas where the payments to these plans and beneficiaries through premium rebates would exceed what it would cost if those beneficiaries stayed in the traditional Medicare program. Most of the additional participants in the administration's estimate are in relatively low-cost, low-density areas where the payments to these private health plans would be substantially higher than the cost of those beneficiaries in the public sector. So that's what you have. Overall, private health plans now receive from the taxpayer 10% more per Medicare beneficiaries than those same beneficiaries would have cost the taxpayer had they stayed in the private plans. I've seen several papers to that effect. And only in Washington would the following sentence make sense. To keep Medicare fiscally viable over the longer run, we shall enroll Medicare beneficiaries in private health plans whose premiums to the taxpayer exceed what taxpayers would have spent on these beneficiaries. Only a Washingtonian would stand before you and look at you and say that with a straight face and expect you to believe that. And I always say, you go into America as distinct from Washington, D.C., they don't speak your language. Their logic is quite different. That if you spend more, it costs more. That's what they would think. And you're telling me this will cost less and somehow make us feel it. I don't get it, but it's cute. If you can't afford a suit, go to Washington now and say you have the same entertainment. This is really cute to have it. Now, in theory, of course, the private plans, if they wanted to and had the guts, they could do us a big favor and get rid of seemingly indefensible variations in Medicare spending. These are called the Wenberg variations. If you go to the web and put in dartmouth.edu/atlas, you get this book. These are not the latest, but it's the latest that it's in book form, based on 96 data, but that hasn't changed. I saw a more recent paper just out in Health Affairs, making the same points, but only within California. But here's what you found. In 1996, what Wenberg does, he assembles hospital market areas composed of counties. And for each county from the Medicare tape, he knows all that was spent on Medicare, that all the checks Medicare wrote for those elderly are on that tape. And he then adjusts these data for inter-county differences in practice cost. Manhattan is more expensive to practice than North Dakota. That's taken out. There may be more older people in Dade County than there would be in Iowa. He takes all of that effect. So you have statistically the same elderly. And in McAllen, in that year, we wrote per statistically equivalent elderly checks $9,000 per elderly. In Rochester, Minnesota, home of the Mayo Clinic, only 4,000. Salem, Oregon, 3,600. In fact, Oregon healthcare is about as cheap as Canadian healthcare. Very much so. So the question really is, what? We have testified before Congress many, many times. I remember distinctly once testifying, we had a hearing on Medicare, and I said, I don't know why we have this hearing, it's not a problem. Just get rid of these variations. And there was icy silence, so I asked later, well, what did I do wrong? And they said, well, you were looking right at the Senator, Bob Graham, from Florida, and you were saying Florida is unbelievably expensive. And I said, that's why I was looking at it. We don't do that here. It's too delicate, to discuss. So Congress has never once paid a dime for research to find out why these differences exist. Well, the Robert Wood Johnson Foundation has spent quite a bit of money on these. And there's several papers, the Archives of Internal Medicine, last 2003. Here's one conclusion. Medicare enrollees in higher spending regions receive more care than those in lower spending, but it doesn't show up in better outcomes or satisfaction with care. And if it doesn't buy you that, the question is, why spend it? There was a more recent study in Health Affairs by Catherine Baker and Amitabh Chandra, and what they did is they plotted, let me just go here, they put on the horizontal axis the spending per capita from the Wenberg study. And on the vertical axis, they put the ranking of states in terms of quality, 1 being the best and 50 being the worst. And this was a study where Stephen Jenks and others had looked at the Medicare tape, and they knew the diagnosis, and they knew what the doctors had done for the patients. And did they do the right thing? Did people get beta blockers after a heart attack? Did they get this? Did they get this counseling? So these are process measures of quality. And it turned out the relationship was negative, inversely related. When what you want that line to be upward sloping. When you spend more, you want better quality care. And then you can decide, rich states may want to go high up and spend a lot on this, right? And poorer states may go and spend less and have a little less quality. Those would be sort of political decisions. The interesting thing, actually, when you look at this, is Louisiana the worst? Texas, not great. California, not great. But New Jersey, not that great either. The big states of Minnesota, cheap. Remember how cheap Minnesota was? Oregon, look at this. And so on. So these are puzzles that I think if managed care could help us get rid of spending that is not needed. With the explanation people make is that areas that stress primary care tend to be cheaper and actually have better outcomes because you catch stuff earlier. And areas where you go immediately to specialists, each very narrowly focused, for some reason rake up bigger bills. But because there isn't a good primary care support under that, patients sort of wander from specialists, like in Miami, where it's just a game to go from one specialist to the other. A physician told me the other day his mom told him she needs another MRI. And he told, it's a true story, he said, but you just had one a month ago. And she said, I felt so good afterwards. So part of that is patients. It's not just doctors. Patients in Miami, they expect that around the Bridge Club. They're going to have a recent episode to discuss. We're not with it. Now there's this new drug benefit that we all heard about. And the reason, why was this passed? Well, the reason it was passed, and these are data for, I think, 2003. 27% of people over age 65 had no coverage for drugs at all, none. Not from an employer, no Medigap, none. 27%. And those tended to be low-income elderly who were not covered by some employer or couldn't afford the Medigap. And even the Medigap had limits of 1,000 or pretty much proscribed. But these had no coverage at all. And obviously in this election, President Bush, to his credit, seized that initiative and says, we've got to do something. And he had to persuade the Republicans, but he did. And it is odd that he would, but don't forget it was Ronald Reagan who tried that before with a catastrophic health plan. Remember that then the elderly themselves destroyed. Those are the elderly who now get kicked off the General Motors retiree health benefit. There is justice after all. I have very little compassion for retirees of General Motors who were losing their benefits, because those were the ones, the people who had employer-provided benefits, who undid what Ronald Reagan did, which was a very benign, very honorable plan for the elderly. Actually, it was not astounding. It didn't surprise me that Ronald Reagan did it. It was a good plan, though. But what it did require is elderly who had coverage through their employer still had to pay a premium to help pay for elderly who didn't have coverage. And those elderly didn't have enough solidarity to be their brothers and sisters' keeper, ran against, abolished the Reagan Health, which he lobbied for personally, and they're now eating it. They're now eating the harvest from that. So anyway, so there is how that worked out. And the act is, looks as follows. For it, of course, it's a very clever trick in a way. How did you get this to cost only $400 billion? Well, you start the meter at 2004, but the program kicks in only next January. It's just like renting a taxi and not driving it for a while and saying, gee, you know, per hour driven is a cheap cab, because you didn't drive it. And so it really starts only in 2006. And so the total spending under that bill is $800 billion, is what is now being said. It's a fair amount of change. And of course the elderly have to pay premiums in there, and there is a clawback from the states, right? So net to Medicare, this is $600 billion, a $600 billion program from 2006 to 2015. If I plot the cost sharing by patients under this act, for up to $250 a year, you pay 100% out of pocket. Then your share out of pocket falls till you reach 2,250, where you spend only about 33% out of pocket, and the government pays for the other 2/3. Then your out of pocket rises again till you reach 70, when your drug bill is 70%, and then it falls steadily thereafter. There was a Chinese gentleman at an international conference who asked me, why was it written that way? And I said, well, there was a clinical study, and I had doctored up a page, making it look like JAMA, the Journal of American Medical Association. I actually have that in my computer. I showed it to him. You know, they did a study, and what they found is that elderly who have drug expenditures between $2,000 and $5,000 have a DNA such that when their blood pressure goes up, they actually are better off. He wrote this law that way, and this guy believed it. There's millions of Chinese who say, did you know this? You know? This is, of course, you can get tenure explaining. But the way this law is, if drawing the picture, I defy you to draw this picture and keep a straight face. It's impossible. So here it is, up to $250, the government pays nothing. Then it pays 75%, up to $2,250. Then nothing for the next $2,850. And thereafter, when the bill per year exceeds $5,100, anything above that, the government pays $90. And you see, they call it the donut hole, but it's the abyss. And a lot of elderly, quite a few, something like 36% of the elderly will fall into that hole. And they'll get very angry because they say, that wasn't the deal. Because it's very confusing. You have to be a geek like me to even be able to graph this thing. Because, you know, you wouldn't expect that normal human beings would design a law like that. But what they have never visited Washington. No, this is not unreasonable. Now you may ask, why was this done? My former student, Bill Frisk, who was part of this. Well, the reason it was done, and I sympathize with him, because I told him, you know, Bill, you should have made the deductible $800 and then not have a donut hole.
Yeah.
And sort of, if somebody really has trouble with $800, give them some special help. But not that many elderly would not be able to budget for $800, right? And those who do, you can help. But he said the problem is many, many elderly don't have expenditures reaching 800. In fact, drug spending is highly concentrated among a few elderly. The bulk of them have health spending for drugs less than $1,000. You'd be surprised. Somewhere I have these numbers. But normally, 80% of all health spending for any age group is done by 20% of the population. It's always like that. And it's true for drugs too. So a lot of elderly don't really have that big a drug bill. So he said those people would never have benefited from this law. They pay a premium, right? And yet they never get a benefit. They say, why did they pass a law? I never get any reimbursement. So he said, if you count votes, this is what you do. Right? So that's why, and then you have to stay within 400 billion. So at some point, maybe they'll fix this thing. Now, this deductible is going to grow somewhat, but you don't see that. The donut hole threshold, which is now 2,250, will go to 4,000 by 2013. So by 2013, you're going to have coverage till 4,000, then you fall into the donut hole. And then you get out of it only at 9,000, so you stay in there for close to $5,000. And your maximum out-of-pocket exposure overall will be with the blue line. So the cost sharing is going to grow quite substantially. This was only a buy-in there. So the deductible that's now 250 will be 437 10 years from now. Does it help the elderly? It really does people who are low income. They will see their drug bill go down 83%. And that's definitely a good thing, I think. On average, all participants will see their drug bill go down 37, but in fact, people who are not poor will see it go down by only 28%. Now, that's a very liberal approach, in my view. This is the thing. I think the AARP did exactly the right thing, supporting this. How could you turn down a deal like this that did so much for low-income elderly Americans? And that is why I'm basically on the side of the AARP. I gave a talk there and said, you did the right thing, in my view, because how could you turn this down and look the poor elderly in the face? Because this won't come around for quite a while. A bill this generous. Now, there will be cost controls. Those of you who've been in HMOs know this will all be administered by private plan. They can use formularies and tiered cost sharing and other utilization controls. For instance, cost sharing, you can have full price or you can have co-payments. They'll go out of style before long, the co-pays, because you just think drugs have free prices. And you never know the price of the drug, you only know your copay. It's really not a smart way to cost share. What you are likely to have is co-insurance, where for the generic you pay 10% for a brand name on the formulary of the private plan that you're in, you pay maybe 15–20% out of pocket. And for a brand name not on the formulary, you'll be paying 40%, something of that nature. And then there is a really beastly thing called reference pricing. Comes out of Germany. I hate to say, but I mean they use it. It's a blunt. It's used in New Zealand, Canada, Australia, Germany, Holland. And this is how that one looks. They group drugs with the same therapeutic target. Say, for instance, controlling blood pressure would be the target. They put all the drugs in one therapeutic group. And then they say, we'll take, maybe not the cheapest, but here drug B is the reference price. We'll reimburse you fully for that. And if you want, for example, drug F, which costs $60, we'll pay you $20, and you're going to pay the other $40 out of pocket. And if you pick drug G, because you like it, you pay $48 out of pocket. That's a very blunt form of cost sharing that would devastate the pharmaceutical industry, because in Germany what happened, all the brand name drugs collapsed to the reference price. So it's very hostile to the drug industry, and it's hostile to the insured, because you're going to be essentially driven to generics unless you're rich. So that may come. So you may want to study up on how that would work. Colleague and I have written a paper on how that would work, but at the moment it is not yet acceptable. And maybe the drug industry will lobby this to pieces and simply say, pass a law that it makes illegal for a private health plan to use this device. I could see that happen, because the drug industry does own shares in the Congress. Now, the beauty of choice, I have learned Americans love choice, even more than motherhood in the American flag. Mazel tov. You got it. You want choice, you got it. In spades. And I hope you enjoy it. I tried to, I'm too young for this. I looked at this. These are the plans in New Jersey. 50 plans that offer, these are the standalones, not HMOs. These are when you stay in the traditional Medicare, then you can join one of these. So there is this thing, you know, Medicare.gov, and you arrive in this thing. And here you have 54 plans are available. This is Princeton. I put 08540. They say, oh, that's so much choice. You know, it's just wonderful. The more, the better. And so I looked at this. So you can have Humana Inc. Standard plan S5884-062. Your monthly premium this year is $443. Deductible $250. Cost sharing, 25%. Co-insurance, remember? No gap coverage. You're in the gap. They cover nothing in the gap. But 95% of all drugs are on their formula. Or you could use WellCare, costs $17.17. See how precisely they're priced. Zero deductible, great. Cost sharing, 0 to 66. I haven't a clue what that means. Or 31% co-insurance. So you have deductibles between, there's no gap coverage, and 81% of the drugs are on the formulary. So what do you prefer? 95 versus 81, but then how about the cost sharing? And that's only 2, and they're 54. So this is unbelievable. There was a survey just on November 9th, they had this conference in Washington. And they asked, given what you know about in general, do you have a favorable or unfavorable impression? 37% unfavorable, 31% don't know, they haven't a clue what this thing is. And 31, less than 1/3, were favorable. And that kind of makes you weep. Here's the Republicans who did a liberal thing, jumping over their own shadow. And they don't get credit for it. No one loves them for it. It's sad. Actually. Seniors who knew something about the benefit, more of them liked the seniors who say they understand the benefit not too well, more of them hated it. How well would you say you understand this? 30, not well at all. 25, not too well. Somewhat well. Only 14%, very well, which is also not too good. Then they say seniors in the traditional Medicare program have to sign up with a private plan to get the drug benefit, yes or no. 32% said no, but they're wrong, they have to. Right? They don't know this, so they'll be in for a surprise, because if they don't sign up, they get a penalty later on. And 33 don't know. It's like at Princeton, I always have this. There are always 10% of the students in my class who are actually not in the class. Someone's stumbled in there and have no clue why they're there, but they're just Mom and Dad paid to sit in the class. Do seniors still have to enroll in this plan to get the new, and again, don't know 42%. And then, you know, where do people get their information from? The pharmacy, only 11%. I think pharmacists will be the big conveyors, could be, of helping you pick the plans, but by law they're not allowed to. The reason they're not allowed to is because Congress fears they may get paid by the drug companies to give you that advice. So it's very complicated to get proper advice. The best thing is the bridge club. Who's least happy, least unhappy with, and then ask what did you pick, and do it that way. That's how I pick cameras. I see somebody say, what is this? Then I go and buy it, because he seemed happy with it. So this is, to my mind, too many options. There is a high potential of regret, because the more options you have, the more likely you will regret. I remember once, when I was a young punk, sophomore, I was in Shawinigan in Canada as a summer intern. And in that town, all the men had moved to Montreal. The town was full of single women, gorgeous. And I had the most miserable summer. Because every time I was out drinking with one, I always said, Jay, look at the one I'm missing. But somewhere else I would have been happy to have one favorite. There were so many. You never enjoyed a single night. And this is what's going to happen with this thing. Only economists and similarly brain damaged persons, human beings, think that too much choice can border on cruelty. And I think this law has slouched that way and needs absolutely to be fixed. So that's the end. I want to stop here. I had some more that has pricing the lower middle class, the young out, but maybe I'll stop here and take questions. And we can get
the Plan D, as you've described it, I don't quite see, maybe I missed something in the literature that I've read. I don't see why there's any dependence on income. You seem to indicate that Plan D is very much more favorable to people who are low income. How does that?
People below 135% of poverty get direct subsidies for the premium, and they don't pay have the donut hole. So if you're 135% below poverty and your assets are less than 6,000, it's free. The whole thing is free. Premium, no cost sharing, no donut hole. If you're 135 below poverty and your assets are between $6,000 and $10,000, that means you have a car, then you may have some copay. Small though, small. No donut hole. So that's how they fixed it. And it's actually a substantial amount of money they put there. The other huge chunk they put by saying to any corporation, if you continue drug coverage for retirees, we'll pick up 28% of the cost of that. Of course, the way they wrote the law, they said, we'll pick up 28% of the cost on those retirees, even if they pay it out of pocket. That is, if you, the company, don't pay it, if you have co-insurance or deductibles on the elderly, we'll add it all up. So in fact, GM could get money for spending the elderly to out of pocket. Why they wrote the law this way? Except you know how laws are made. Some lobbyists got that done. So in a way, I think that was an unfortunate way to do it, because it gives the company the incentive to increase cost sharing on the retirees and yet get 28% one way or the other, which is almost asking for it. You know, it's just like having a big sign, kick me. I don't know why and again, that'll get fixed. You know, this thing.
I understand that there's a difference in this law versus the Veterans Administration or other programs where the government is allowed to contract with pharmaceuticals industry for bulk decreasing in price. Can you address why is it not going to be able to get bulk discounts in this Medicare Part D?
Well, the Medicare gets Medicaid rather gets traditionally covered drugs. It's voluntary by states, but all states do it for the poor, including the elderly poor. And they got good prices. First of all, they got the lowest prices that drug companies gave anyone else, plus a rebate under the table. So the states bought very cheaply. The VA buys, as you say, they sit at one end of the table. We got lots of veterans, and we want a good price. So they have a formulary. The VA is now considered the most efficient buyers of drugs, and actually the most efficient health system there is, with the highest quality. I don't know if you knew this. Yes, within the last decade, they're now considered cutting edge in terms of IT, quality assurance, and that. But it's still manageable. If you had Medicare would be paying for close to 40% of all drugs used in the US for the elderly. So you have one big gorilla facing a splintered drug industry. Because the drug industry is not that concentrated. For a lot of on-patent drugs, there's more than one product that you could use. So the drug industry feared we would sit like with this big gorilla. They will pay us prices that don't cover our fixed costs, our R&D costs, and therefore we'll get shafted. So they basically prevailed on Congress to say, you got to weaken the buy side. And the way you weaken it is splintering it into 54 little plans. None of them have market power. And the Congress has ceded to that. Whether that'll stay, I'm not sure. But the other side, you could say, if, for example, you could imagine, I tell drug company executives, in the long run, this could hurt you because if these 54 plans, they're not all different companies, like Humana might have 4 different options, right? But they're probably something like 15, 20 players in New Jersey. They're not going to last more than 4 years. They'll all buy each other. You know, somebody will make a plan like that, run it for 2 years, flip it to a larger one, and then walk into the sunset with a couple of $1 million. That's what happens. So in the end, you might have 3 or 4 big buyers for all of New Jersey. And I tell drug executives, those guys, lobbying won't help, nothing helps. You can't bribe them because these private executives, they got their bottom line, they got their stock options. They're going to drive very hard bargains with you. Well, with the government, ultimately, you can always appeal to science policy and say, if you set the price too low, we can't do R&D. I think the government, in the end, is a bigger patsy than a bunch of stock option-driven executives will be. I think, in the short run, no. In the short run, I think with this chaos out there, the drug industry can write its own ticket. But that won't last very long. The shakeout will come within 3 to 4 years. Then you have Express Scripts, you know, Oxford, Blue Cross, the big, big buyers who will do that. And I think they'll be a lot worse to deal with than, you know, the lobby. You see that with the hospitals. And does anyone here know about the Balanced Budget Act of '97, where the government passed a budget law that was brutal to the hospital, damn near wiped out the home care industry and the skilled nursing industry. So the hospitals literally had their payments frozen for a year. And then came the givebacks that Congress said, oh, we were too rough. And in return for campaign contributions and lobbying, year after year, there was a give back till it's back on track. I sometimes wonder if Congress does that on purpose, saying we're going to put a brutal law in to scare the hell out of all these guys. They will then pay us a lot of money to give backs, right? And it's a business. Congress has become a business. After all, it's a huge cash-hungry machine. And this is one way to get cash, is every so often to brutalize people, but you wink at them and say, don't worry about it. We'll give it back to you, but you've got to empty out. Why is that a good deal for the associations? If you run the hospital association, what you pray for is a law like that, somebody whopping your industry, right? And then you go to your members to say, we're going to lobby for you, we're going to get this fixed. And so please, you know, make PAC contributions. And you then go and give the gift backs that the congressman has already told you you're going to get. And you, as an association head, look great. You say, hey, look, these guys, they got us a nice gift back. The AMA plays that game. Every year, Medicare says we're going to cut physician fees by 4%. every year. And every year when it's done, it's up between 1% and 2%. This year again, I already know, right? But they were announcing 4. Why is that good for the AMA? Well, it's great for the AMA. You go in and you basically say, scare the hell out of my members. So then you do, and then you tell them, we're going to fight for you. And in the end, you get 1.5% to 2%, right? So the association looks good. The Congress looks good because if you hadn't done this, you probably would have had to settle for 4% plus. In this way, you get 2. So it's a very cynical game that's being played. And the typical physician who's very busy and believes all this gets constantly exercised every year. Blood pressure pills get eaten because of this scarcity. You probably were madder than hell again this year. You shouldn't be. I'm telling you, you're going to get 2. Don't worry about it. But it's this game that people play. So I think in the end, the drug industry made a mistake.
Could you comment on universal health care and whether you think it will ever happen?
There's this story where they asked God, somebody who'd been all his life a health policy monk, went to heaven, where we all go, and asked God, I spent my entire life fighting for this, will it ever come? And God says, yes, but not in my life. That's my answer. That's how I opened this paper. I don't think we'll ever do it. I just don't think we'll do it. I don't frankly know why that is so, but and I've written a paper on that to say we are very harsh to people we call losers. And our definition of losers is very loose. A woman who got married, has 3 kids, got divorced, sits there making $25,000, uninsured. And we say, you're a loser. You shouldn't have gotten married, and you shouldn't have had kids, and you shouldn't have gotten divorced. Say the very same congressmen who are on their 3rd spouse. I don't know why we are this harsh, but we are. And I'm a military family man, as you know. And I am shocked that we had this pancake sale here in Lawrenceville, where they were collecting money for a pantry for Guardsman's family. And I said, how could, something so honorable is to go over there and stand tall for us, and their spouse has to go beg for food. Why do we do this? I wrote an article for the Wall Street Journal, an editorial on that. They wouldn't publish that. Because I said, yeah, you're going to have to raise some taxes to do this. They wouldn't, no, they wouldn't publish it. That would be beyond the editorial page of the Wall Street Journal, which I think is very sad, because they express that view, and everyone says this is hunky-dory. I have lots of other ideas for military people, for enlisted men and women, when they come out after their 4 years. Why don't we make an enterprise fund, $200,000, saying you can use that either for college, which we now do, but if you're not fit to go to college, not temperamentally, intellectually fit, you want to be a partner in a limo company or in a gas station or something on Main Street, you can be part of us, capitalists like the rest. $200,000-300,000. Do you think I could ever get that in the editorial page of the Wall Street Journal? I doubt it. Because they would say, you're talking about taxes. We say, yeah. They fight for us. We should pay taxes. I don't know why we don't, and for that same reason, we will not cover the uninsured. I always tell people that people who are uninsured, think about who made your life comfortable today. It was a cab driver, it was a limo driver, it was somebody who delivered milk. Those people are all uninsured. Our daughter is a physician in Boston. We went to a Chinese restaurant, and this guy was sick. He said, I coughed and spit up blood all over. So we said, our daughter is just down in Tufts, so go to see her. So we called her. She says, I'm not allowed to see him in clinic if he's uninsured, because we have a rule. He can go to the emergency, but not me, where I am. So, she went to see him in the restaurant and said, it could be just an ulcer, you could have cancer. And so you have this problem. How do you pay for this hard-working guy who just served you food? I don't know why we are this way. It would cost, actually, I have it here. We're not talking about an arm and a leg. You could do this. This is the income distribution of the United States, 2002. I always kid and I always say, gee, I always thought all America was in that red line, because everyone in Princeton seems to be. But you see, 33% of American families have an income of less than $35,000. That isn't a lot. Why? Because an insurance for a health care for a family today, for an average young family, average over sick and healthy, is $12,000. That is what the average premium is for an employer, for a family of 4. The premium the employer pays plus the employee's share plus out of pocket is minimum $12,000. And so you have this income distribution, but let me show you some numbers that, yeah, I saw this here, 18,000, 1 in 4 workers makes less than 18. And so you ask yourself, who are these people? I never meet them. And say, yes, you do. Go to Walmart, Home Depot. That's where you meet them. These are the people, you know. So if you assume someone has a family income of $35,000 a year, and that income grows at 3% per year, which is what we're talking about in this U.S. economy. Cost of healthcare for a family of 4 is $12,000. Let that grow at 8% per year, which is sort of what it's been growing at. And then if I now plot the family's income of these bars to 2015, the healthcare cost is the green. So 10 years from now, over half the income of that family is chewed up on healthcare alone. And that means 8% growth, which is what it has been. Then you say, well, you blame the doctors, but actually doctors, on an after-tax basis, take home only 12% of total health spending. Drug spending is about 11%. So there is no real culprit that you can pick on. It's just expensive to do. And so, you know, facing this, we, in this decade, face whether we want to price these people out and simply ration them out. Because, you know, you cannot ask a doctor who has medical debt, kids in college, to somehow step in for the taxpayer and give free care because of a Hippocratic oath. If you read the oath, it says nothing about charity care. It says you shall not harm your patient, or sleep with a slave and stuff like that. But it does not tell you, yeah, it says that, right? And only your sons should be doctors, not daughters. So it's you know, that oath had very little to do with charity care. It just means first do no harm. So you have this, about 100 billion of a GDP of 14 trillion, or 13 trillion now. It's not, wouldn't sink the republic. You know, it's sort of 1 year of Iraq. So it's not really that big a deal. You know. And we were in 2000 the least taxed nation in the OECD. All taxes, federal, state, local, sales, you name it. 29. And now with the 2 tax cuts, we must be the least taxed nation in the OECD. So, you know, my view is basically we could afford this, but whether there was a Democrat in the White House and a Democratic Congress, or a Republican or mixed, has never made any difference. We never did it. I was an advisor to Bradley. I thought he had a great idea. He was going to spend on health care as much as George Bush Sr. promised to spend in 1992, I guess it was, February, Cleveland speech. They were spending, you know, in now dollars, roughly $65 billion a year. That would have more or less done the trick. And in fact, as an advisor, we persuaded Bradley to use George Bush's plan, Senior, a little bit fixed up. They said Republicans can't really oppose you on it because they developed it, right? And he bought this idea. And then it was, who ran against him? Al Gore, who called him a big spender, reckless spender. So you had a Democrat devouring another Democrat who was going to spend no more than George Bush Sr. You see, the politics confuse me in the U.S. So I think, you know, you can blame it all on one party, but no, it's bipartisan. It's never been. So I don't think this is going to come about.
I'm a scientist, and I was involved in the development of coronary stents.
Oh yeah.
And I know, and I'm sure that you know, that products like that are priced not on what it costs, but on what the market will bear.
Oh yes.
Is there a way to do something about this as a way to control future healthcare costs? Because there are going to be a lot more products like this which do wonderful things.
Yeah. Well, I mean, let's first of all not stent so much, because those stent prices are going to come way down as the old stents. Remember the non-drug eluting stents? They were very expensive when J&J initially had them. Then you had competition come in, and they go down. And this will happen to the drug eluting stents as well. But people often pick on the profits of the pharmaceutical industry, which as a percent of revenue are high. It's 20%, 18 to 20%, maybe a little less now. But, in fact, somewhere here I have a slide that shows total drug spending, of total drug spending, which is about 200 billion a year now. The drug industry and manufacturers get 3/4 of that. And then about 1/5 of that is profits, right? That turns out to be about 1.3% of total health spending. So the profits of the drug industry, it's about 3.3% of all health spending, which says if you got rid of all these profits, you would reduce health spending by that much. Now the device industry makes bigger profits than the drug industry. They are, but it's not that big a piece of the pie. It's a small sliver of the pie. Each of them do make a fair amount of money, but they don't make hay for very long, these industries. A lot of their energy gets consumed suing each other, which you will. No, really, I mean, it's not the malpractice against them nearly as much as that they constantly sue each other over patent infringements. Because with the stent, for example, you know, they're all very similar. It's just the way the structure of the stent is and how the drugs are put on there. So, yeah, they make a lot of money, but you wouldn't really give us the relief you want in terms of overall health spending. What the real money eater is the hospital, 40 cents of every health dollar. Is there a lot of room to cut? Where we have a nursing shortage globally. You know, the Brits steal from Ghana, Canada steals from the Brits, we steal from Canada. It's sort of a chain of stealing of nursing. Nurse in California now makes more than a pediatrician if she's critical care, because they're so scared. So all this is going to bang down on us. The shortage of nurses, shortage of cytotechnologists, shortage of a lot of hospitals. So hospitals, profit margin is very low, 4%.
Yes, this is out of context, but earlier in your talk, you said that if people who were on private, seniors on private plans would be better off staying on them. And I'm wondering if that has any bearing on the situation. And also, I just wanted to comment on that. The reason you don't see the $18,000 people is that apparently people making, a family of four making $23,000 calls themselves middle class, and a family of four making $200,000 calls them middle class, themselves middle class. So you don't see them because they don't tell you, because they think you're middle class.
Yeah, which is touching that they do. I tell my students I'm rich, and they get very offended. Professors shouldn't be rich. But I said, if you look at professor's salary, it puts me in the top 10 percentile of the income distribution. I'm not entitled to write home to mom saying I'm rich. When could I ever write about it, right? When you're in the top 10, to me, you're rich. outrageously rich, but I don't know why we have this attitude. Now, these people who work at Walmart, I often am amazed why they are so cheerful. They have I sometimes tell them, why are you in such a good humor? I'd be so ticked, you know. They're the sweetest Americans. They are, actually. That's why I'm their champion. Because they really are wonderful. They make my life so comfortable. And I'd be willing to pay. I think in New Jersey, we're not so bad. I mean, let's face it, we pay the income tax without much complaining. And it did a lot of good, I think, at least for the schools and so on. But parts, particularly the Sun Belt, I'm just amazed how harsh people are towards the poor. So, now, staying in the plan, I didn't say that. What is the best thing for you to do? I mean, if you're in a good health plan, I personally could imagine that to be a good deal. You know, if they manage your care. But you'd really have to know what kind of plan, what is the formulary. It's a very restrictive formulary, and you have mental illness, you might be in bad shape. Because at least mental health specialists tell me their drug substitution is not so easy. Certain drugs work for some people and not others. It's easier maybe for, well, even blood pressure, I don't know, even blood pressure, right? Not every drug works for everyone. So it's very tricky to have these restrictive formulas.
Perhaps one more.
One more.
My experience with various industries moving up through time has been the learning curve kind of dominates things if you step back and look at it, and every time you double the production. This doesn't seem to happen at all in the drug industry. And why not? Is there something really different between that and manufacture of TVs or computers or solar cells or something like that?
Well, I mean, the learning effect that you're talking about, where every time you double output, average costs go to 0.75%. That's aircraft, fighter planes have that. That has to do with the fact when you have a very complicated product that is kind of handmade, put together, the learning is so enormous that people really learn you should really put that part in before that, and you know, and so on, that you have these effects. But drugs, once the R&D to make a drug, you know, you start with 10,000 compounds, one will make it to market. And all the phases, you know, the preclinical and the 3 phases and the approval, on average it's been estimated cost $800 million per successful drug, assuming they carry the load of all the dry holes that you drill. And so that has to be amortized. But once you know how to make a drug, you just have these machines, and they run. I mean, you may have the first batch till quality assurance is there. But it's then totally flat, so there is no learning. So it's the drug prices, as this gentleman said, have almost nothing to do with cost. It's what the market will bear, is what they charge, right? And then the question is, why has that been so lush? Because the market, the buyer's market, has not flexed its muscle. There was no muscle there. Look at how it went. You went to the doctor, they wrote a script. The doctor may know the drug, but often not the price. You know, the doctors don't look at the price list. You go to the pharmacy, and some gum-chewing kid tosses you a bag and say your copay is X. That's not a market, right? And it's because of the absence of market power on the demand side. The supply side could dictate prices. I think that'll change. I think the Medicare drug law, what the real sleeper and what the drug industry should really fear is there'll be in every locality a website listing all the drugs and all the prices at every pharmacy. That'll happen within 2 to 3 years, right? And never before did you actually have commoditized drugs this way, that you have total price transparency. And I think that is far more dangerous to the drug industry in terms of the revenues than anything else coming down. Like formularies, all that is nothing compared to this transparency. And to the druggists, because even within Princeton, the same drug, you have quite a few differences in the markup, you know, that. So I think that is what's going to give strength to the humanity. It's a very exciting field.